Hello, I'm Dr. John Kruse, and welcome to today's question and answer hour. So we have time today for me to try to answer questions about the videos I released this week about ADHD topics in general or the broader area of mental health. And a reminder that the information I put out here is for general information purposes. I am not making specific recommendations. Please take this information to your providers, prescribers, treatment team, and hopefully make good use of them there. And related to that, and commenting on one of the first questions I see there is someone wanting to set up an appointment with me, and I am flattered by the interest, but I'm actually not taking any new patients or nor any consultations. So I've been trying to focus my time in the last 2-3 years on reaching a broader audience and helping lots of people a little bit rather than a few people a bigger amount. So as of now, and I'm not foreseeing that changing, I'm not taking new patients or consultations. And I would say there are other intelligent, caring providers out there. There are also, unfortunately, a few who probably shouldn't be in this field, but I don't think that I am unique or special in that regard. So the two videos that were re-recorded this week. One was on nature and ADHD, and one was on breathing exercises. So with nature and ADHD, there's a lot of common sense, a lot of experiential, anecdotal information that being out in nature helps someone be more focused, helps them feel calmer, helps specifically with ADHD symptoms. And there are actually more than a handful of studies. There's a handful of studies on the direct immediate effects. So there's a study taking a walk in nature versus in a park versus walking in the same city, but in not a dangerous, risky environment, but just an urban setting, and measuring verbal recall abilities and other executive functions after that shows that kids with ADHD do better after just a 20-minute walk. There's also a larger body of evidence looking at nature exposure, greenness of childhood environments, and subsequent rates of ADHD, and children who grew up in greener environments, children who grew up in less urban environments, and they are independent variables to some extent, have lower rates of being diagnosed with ADHD. The theories for how this works are, some of them include not purely because it's all interactional, largely biological mechanisms, so that you change your microbiome if you're living more in nature, or that there are different immune effects, different toxins in urban versus rural environments. But there's also three theories. One is biophilia, that we have an innate love or affection connection with nature. Two is the attentional restoration factor, which posits that our brains are wired for natural environments, not for indoor and urban environments, and that this causes excessive strain on our specific executive functions, attention among them, and that replicates symptoms of ADHD, and that being in a natural environment can restore it. And then the third one is what I call the parasympathetic promoting effect, that for many people, the urban environment causes more stress, more noise, more discordant events, more interruptions, and that puts people in an overly sympathetic, revved up environment. These theories are not mutually exclusive, and if anyone wants to talk more about them, we can jump into them. Second video is sort of overlapping or connected with this one, and that was about breathing exercises in ADHD. And again, there's a lot of anecdotal claims that Wim Hof approaches or other people's breathing approaches, yoga approaches, may help with ADHD. And more broadly, there's evidence of helping engage, again, parasympathetic nervous system and calming and soothing people, helping reduce anxiety and sleep. There's a little bit of evidence suggesting that some of these approaches may be helpful in the setting of ADHD. And certainly the cost is low and the side effects uncommon. So that's what I will say about these talks, and I am open to questions now, and I see there's a bunch of questions sitting there. So Dennis asks, what are some examples of ADHD with organic etiology? So this is a question that's by the DSM description, not necessarily completely embedded in all of its criteria, but the description is that ADHD is a neurodevelopmental condition with a very large genetic contribution. The heritability is about 0.8, which is not saying that 80% of it is due to genetics, but it's saying that this is it's the amount of variability due within the condition is due to genetics. And by some of these official definitions, if, for example, you have lead poisoning exposure, so we know high levels of lead in your blood are strongly correlated with a range of ADHD symptoms. We know that fetal alcohol syndrome, so prenatal in utero exposure to alcohol, very often shows up among other symptoms with it is a complete ADHD picture. Whether, if we can ascribe it to fetal alcohol, whether we can ascribe it to lead poisoning, whether that means then it's not officially ADHD, because the ADHD criteria, again, almost all DSM is a rule-out basis. So some would even say, even in those situations, even though it's happening early in development and symptoms are showing up about the time that more classic ADHD is showing up. So there's debate within the field as to where we draw the lines. I think we're moving more towards the domain criteria, research domain criteria that NIMH and other organizations have sort of recommended, that we base our mental health diagnostic system more on known pathways within the brain and circuitry for specific functions and deficits or challenges or deviations from the norm on those patterns, and that much of what we consider ADHD is associated with prefrontal executive function circuitry that's not working well. So if we sort of embrace that view, then even later in life, other organic etiologies of ADHD syndrome, a collection of syndromes, a complete collection, would include, again, not just early life in utero exposure, but head trauma. Very often head trauma, particularly to the prefrontal cortex, can replicate ADHD symptoms, where we would look at things like post-COVID syndrome, where the most common disabling collection of features of post-COVID, long COVID, is fatigue, lethargy, troubles with organization, troubles with memory, which that's a pretty good overlap for ADHD symptomatology. Again, in these situations, the immediate insult or trauma or infectious or inflammatory process seems to be what's going on, but we know, multiple people who have long COVID, or many people get COVID, they don't all develop long COVID. So there are almost certainly pre-existing genetic factors predisposing people. Even with head traumas, it looks similar. Some people respond with minimal long-term effects, some have severe long-term effects. So I think we can't just say this group is genetic, this group is environmental. It's always both. So that's my way of sort of fudging it. A lot of that is what's embedded in the book that I'm writing. And unfortunately, things are slow in the publishing world, won't come out till next year, but it's 2/3 written. So G says, is it true that people in Eastern countries like China and Japan have a more developed right brain hemisphere compared to people in Western countries like the USA and Canada? So this is not my area of expertise. I have written a little bit and talked about, and I do have a video on left brain, right brain. I think part of this is based on different language systems, and I'm not even going to come up with the right terms, but if you have pictorial, characterologic based language systems like Chinese, Japanese, to my knowledge, Korean, compared to phonetic systems like most Indo-European languages, there may be some differences in the strength of lateralization for language. So I will leave it at that. For me, part of and I'm blanking on his name, Mick, who's written extensively about left brain, right brain, and I think some of it is actual real lateralization, but I think some of it is more metaphorically describing different attentional systems, and left brain being more reductive, fact-based, and right brain being more holistic. Anyway, I'll stop there unless someone wants me to go further into it. Hi, Max. And he's referring to the Nature video. It seemed like the studies were pretty light on taking into account confounding variables, like there are so many factors that could influence some of the results. So I didn't go into the details, but many of them are quite aware that there's a strong correlation between what environment you live in and your income and your parents' education levels and how likely you are to be smoking and prenatal toxin exposure. So many of them have done a fairly thorough job of trying to rule out these other confounding factors to either control for them or account for them. So I didn't explain that in detail, but I think actually they've done it pretty well and evaluated, which was from sort of Landsat or other satellite images of each neighborhood down to a fairly discrete area. They could see how green or blue, so open water is considered nature as well. You can get a fairly good idea of what the immediate environment of kids growing up is. And they also had a separate measure of urbanicity, which was population density based. And again, if you are in New York City and live right next to Central Park, or if you live in San Francisco and are right next to Golden Gate Park, that's very different than living in the Tenderloin or living in the middle of the Bronx or some other neighborhoods. And interestingly, they could find, and I'm trying to get this right, but my recollection is that for urbanicity, there's a fairly linear relationship. So the more urban it was, where you grew up for the first decade in your life, the more likelihood you received an ADHD diagnosis. But the effect of nature immersion, the greenness, was more, I would say, probably a threshold effect, that as long as you were above a minimum amount, then that had some protective effect. And if you didn't get that, you were more at risk. But it wasn't this linear relationship. And also the fact that they could separate out, it wasn't the very first 2 years of life, so it wasn't you were preset for life based on very early exposure. It was more the duration, extensive exposure. So again, I think that study and others have controlled well for a variety, to be able to tease out the effects of those factors to that extent means they had controlled for a whole bunch of other potentially confounding variables. But good point. And so Dylan Knatzer asks, are Strattera side effects likely to subside with time? How long should one wait before quitting? I'm having headaches and urinary issues. So I do have a video on, Strattera on atomoxetine. It's mostly a specific norepinephrine reuptake inhibitor. It does have some glutamate blocking effects as well, and MDA receptor blocking effects. So it's not just a simple norepinephrine reuptake inhibitor. I will maintain that most of its effects are quick and immediate in terms of benefits. It's just that most people can't tolerate a therapeutic dose, so people have to titrate up on it. But Dylan's question is more specifically on side effects. So why I don't like it is it's just less tolerable for lots of people than even the stimulants or even serotonin and norepinephrine reuptake inhibitors like duloxetine. So some of the side effects can wane or disappear completely over time, and specifically headaches are less likely a few months into treatment than early on. Urinary issues can wane, but there are also some people who very consistently continue to have urinary issues or even headaches while they are on it. So it's kind of a non-answer. So some people, yes, they go away, and some they don't. And I don't know what to say. I mean, I can't give a formula for yes, you should stick with it for 11 to 12 days and then give up, because it clearly depends on the severity of what you're feeling and your willingness and what else has provided help or what hasn't provided help, what's been eliminated or not. Hello, Jonathan. I'm doing well today. I'll speak out because some of my patients have mentioned it. I was not hit or attacked or anything like that. These are, ironically, as I'm promoting nature and immersion in nature, I was a nature boy growing up. I was blonder. I did have hair on the top of my head then. So lots of sun exposure, skin damage. I mean, since my very early 20s, I've always worn a hat when going outside, but as a kid, I didn't. So I have some 5-fluorouracil treatment to avoid things from changing from precancer to cancer. So Max has provided so thanks for bringing up. So I have talked about Gabor Mate. So Gabor Mate is a Hungarian-Canadian general practitioner, I think with some training in cardiology, no specific training in psychiatry, who wrote the book Scattered more than 20 years ago and has written subsequent books. And his thesis is that all ADHD is because of a mismatch between parenting, and mostly the mother's fault, and not providing the kids what they need or seeing it from their point of view, and that's traumatic. Clearly, trauma can replicate or create a variety of ADHD symptoms. Clearly, people with ADHD are more prone to trauma. So but I find much of what I think he means well, and I think he writes incredibly evocatively and powerfully and conveys that he cares. So what he writes resonates with lots of people, and he has a big fan club and following. But the basic thesis just is not in accordance with observable facts, and that is a considerable proportion of people with ADHD don't have any substantial trauma and wouldn't fit not just a PTSD, but even a complex PTSD scenario. 2, all the studies looking at the genetic contribution suggest that the genetic contribution to ADHD is very substantial. 3, rates, and this is hard for many people to accept or believe because we talk much more about trauma and we talk about the Me Too movement and we talk about there's clearly way too much trauma that's still going on. I think if the attitudes of the people who are powers to be, who are in power right now in the US government, which emphasize bullying, which emphasize abusing people, which emphasize taking things from others, I think that will increase the amount of trauma at all levels of society. So we're in a midst of a bad experiment. So too much trauma. And yet, when you look at rates of severe trauma, very consistently, large numbers of studies show a very dramatic decrease in childhood trauma, largely because I think, and there's theories of why, it's that we told people, no, you shouldn't be spanking kids in school, you shouldn't be beating them at home. Do some people do that still? Yes, but it's much less socially accepted. And that's resulted in a dramatic decrease in childhood, severe adverse effects. And you would expect if that were the major contributor to ADHD, ADHD rates should be plummeting as well. They haven't. So the trauma theory, there is a connection, but is the major contributor, is the only contributor, or is the essential contributor to ADHD is just false. I'll say it there. So Dylan asks, if someone is diagnosed with ADHD but hasn't started meds yet, is it a good idea to get their hormones checked, testosterone, estrogen, cortisol, thyroid, before starting meds? So this is going to be more philosophy than science, or merging the two. I think American medicine places an overemphasis on lab tests, and I think a lot of it is cover your ass laziness. That if I didn't check this and this and this, and it later turns out this very rare thing was responsible, then I could get sued for missing it. So one, yes, there can be physiologic contributors to ADHD symptoms, but things like sleep apnea are probably way more likely than a testosterone or estrogen or cortisol imbalance to create it. Secondly, and generations of medical doctors and medical writers and medical philosophers and have observed that a careful history is usually your most effective tool. And that requires not just having an exhaustive knowledge of all the possible symptoms and asking about temperature and tolerance for thyroid or changes in your hair, but it also involves knowing who your patients are and knowing how to listen to them. Some people exaggerate symptoms. Some are sort of hypochondriacal. We use less pejorative terms these days. Some, on the other hand, are stoical, and they'd say, it only hurts a little bit, and they're walking on a bloody stump of a foot. But if you need to know who you're talking to and how to listen to what they're saying to know what's going on. My take, and maybe I'm more thorough in asking her, is that almost all the physiologic conditions that could be contributing to ADHD, you will pick up on and are likely causing other symptoms in other systems of the body. So if someone is coming in brand new at the age of 40 and claims they didn't have ADHD before, then absolutely you should be looking strongly at possible physiologic contributors. On the other hand, you should also be strongly looking at other measures that might indicate they really did have ADHD symptoms for decades, and they just had other ways of outsourcing their executive functions, or people picked up for them, or they found friends and family and work environments that worked for them up until now. So, but again, it's listening to the person and listening to their story. So I am not big on getting a whole battery of biological tests unless there is already some indication that there are something meaningful going on in those realms. So thanks, Max, again. So it's Ian McGilchrist who's written his first big book was The Master and His Emissary, about the left brain, right brain differences. He's a neuroscientist and a psychiatrist. It's an incredibly detailed 5 or 6 or maybe even 700 pages, including 100 pages of footnotes, documenting left brain, right brain differences and how we've oversimplified them. And I might have oversimplified and misrepresented some of his thoughts. Cesar Masso, greetings from Mexico. Hello. Can I recommend a book or video to improve sleep quality? I think Matthew Walker's book, Why We Sleep, I believe it's called, is quite well written, quite entertaining, quite thorough, quite approachable. So that's a good, it was a New York Times bestseller for years. I mean, it's not that old, but for the several years since it's been out. A simpler approach for years, Stanford was considered one of the sleep center there, one of the leaders in the field, and still is. I believe on their website they still have, a list of 20 pointers for what constitutes good sleep hygiene. I have a handful of videos, particularly the older ones on this channel, that can specifically address sleep in the setting of ADHD. So hopefully that's at least a start. So Max is saying, anytime I hear about the autonomic nervous system, it seems so bizarre and mysterious, especially the graphs, which make it look like some interconnected web of weirdness. Can you explain it like I'm 5? So I'll, at the risk of oversimplifying, and again, it's probably not my area of expertise, although I know some about it. So our non-autonomic, so most of our nervous system, when we think about what our nerves doing, our nerves are firing our muscles, our nerves are providing interoceptive information from our body about temperature, about position of limbs, about pressure on the body. Our sensory systems are feeding all that in. Much of that we can be consciously aware of and choose to direct or filter it. So the autonomic nervous system is autonomic, means it's functioning on its own. We don't have to think about it. We don't have to direct it, but that doesn't mean we can't intervene and change it, some parameters of it. And at the most simplistic level, the autonomic nervous system is divided into 2 main branches or functions, and one is the sympathetic nervous system, the fight or flight system, which, when activated, increases heart rate, increases blood pressure, constricts blood vessels throughout the body, changes blood flow within the brain, shifts blood away from the digestive system. And the parasympathetic system, which some call the rest or digest system, is involved in relaxing, dampening down, sort of reversing all of those things, shunting blood to the digestive system. For sexual activity, you need actually to have the right amount of both parasympathetic and sympathetic tone. So it's not that one of these shuts off the other completely. So you have to have the level of arousal and responsiveness, but not be so uptight that you can't perform. What else? I don't know if that's too simplistic. The vagal nerve, which is, vagus means wandering nerve, from vagrant or vagabond, is responsible for much of the parasympathetic nervous system. I guess I'll leave it there, and if that's not helpful enough, we can go back to different pieces of it. Hello, James Alexander again. Should there be any therapeutic difference between different delivery options for extended release non-stimulants, such as clonidine XR pills liquid, where serum levels vary, versus steadily release patches? So clonidines, so 2 things. Most of our non-stimulants that are used for ADHD, so one is indirect effects versus direct effects. Many of the experts, and I disagree strongly with this, and many of them have come around a little bit over the years, or saying things that are more, I think, in line with reality. For years, you'd go to a prominent ADHD expert's lecture, including medical doctors, and they'd say the stimulants all work quickly because they're releasing dopamine and norepinephrine right away, and they're causing their effects. The non-stimulants are more like antidepressants, and they work slowly and takes a lot of time. So it'll be weeks before you know what you're getting. I think a lot of that confusion was caused by Strattera, atomoxetine, which again, so back up. Most of our non-stimulants, bupropion, atomoxetine, duloxetine, tricyclic antidepressants that work on norepinephrine have effects on the boosting norepinephrine, boosting dopamine quickly, immediately, within minutes to hours. And on that basis, you would expect those to work immediately for ADHD. And if you actually talk to people, and maybe it's more important to listen to people, and I do, virtually everyone who gets a good ADHD response from Wellbutrin or I'll again jump back to Strattera in a minute, or duloxetine or modafinil will tell you, I could see the effects right away. That day, that morning, it was working. Now, the problem with Strattera is so many side effects that people need to start at a really low dose, and they're not at a therapeutic dose. So for drugs that work immediately, the delivery mechanism is often quite important, and particularly with dopamine systems, we know that it's not just the concentration of dopamine at one point in time, but how quickly that concentration is changing. So flooding the system with too much at once can have a different effect than reaching that same peak more gradually. I'm getting away a little bit from the question. So even with many of the slow release or many of the non-stimulants, so bupropion is a good example. When it first came out for depression, it was an immediate release form. Most of it's dumped into your body within 4 hours, blood levels. And it was recommended as a 3 times a day drug, which meant many people were taking it at bedtime, which is overstimulating for many. And they came out with Wellbutrin SR, which was a twice a day, and then Wellbutrin XL, which is a once a day. And the difference between the two of those is actually fairly small. So it's not that one is a 12-hour delivery and one's a 24. We can get into that issue. But clearly, people who experience benefit for their ADHD, it shows up usually more quickly, more robustly with the immediate release version. It is tracking the blood levels in your body. So with clonidine and guanfacine, though, the alpha-2 agonists, noradrenergic agents, I might be saying that wrong. Most of their benefit for ADHD does seem to be indirect, does seem to take weeks of time. So when I say indirect, Wellbutrin has immediate effects on ADHD, immediate effects on attention and energy, and slow effects on mood as an antidepressant. It's not because it takes a long time to build up in the body. It's because how it's working for depression. And if I knew exactly, I'd have a Nobel Prize. And I don't have a Nobel Prize, and nobody knows exactly, but it's almost certainly how Wellbutrin messes with dopamine and norepinephrine, serves as a signal to the brain indirectly saying, hey, brain, start doing a couple things. Start making some new proteins, start inserting those proteins in cell membranes and changing how nerve cells communicate, start making new proteins. Did I say that already? And start making maybe even new nerve cells. All of those take a long time to build up till they're at a level where they're impacting overall brain functions. So the same drug can have very different courses of action for efficacy. So with clonidine, I think in terms of benefit or for ADHD, it's unlikely. I'm more familiar with the guanfacine literature. Guanfacine immediate release and guanfacine extended release both have numerous studies showing efficacy for ADHD, and they both show that it's a slow indirect effect. One of the issues with clonidine and why is that clonidine, so both clonidine and guanfacine are working primarily the same way. There may be some subtle differences between additional things they do. So with our indirect processes, at least for depression and probably for ADHD, unlike when we're treating epilepsy, when we're fighting an infection, where maintaining a steady level, or at least having a level in your blood above a critical minimum, is absolutely essential, because if your antibiotic dips too low, you're not killing your microorganisms. They're proliferating and probably developing tolerance. If you're below what's a anti-seizure effect with the anti-epileptic drug, you're going to be at risk for seizures. So with those drugs and those substances, maintaining steady levels are quite important. With indirect effects, so those are direct effect drugs, or direct effect actions of those drugs. With indirect effects, getting a strong enough signal frequently enough is what matters. So we know with antidepressants, particularly once they've started working, once they've been working well for a few months, you can stop Paxil 2 days every week on the weekend, particularly, and people have done this to get rid of sexual side effects, which are an immediate direct effect related to the amount of drug in your blood, whereas the beneficial effects aren't. Where have I lost my train of thought there? So with clonidine and guanfacine, with clonidine in particular, what's problematic about it is that if the level of clonidine drops too quickly, there's what's called rebound hypertension. So clonidine originally was developed as a blood pressure lowering drug. It does that well. But if you stop it too abruptly, it doesn't just leave your blood pressure where it was before. There's a rebound, dramatic increase often. And so people who are, let's say, running in the 140s and 50s and took it because they needed it, as in rebound, their blood pressure may shoot up to the 180s or 200, range where you're at risk for stroke and other damaging effects. Guanfacine doesn't leave the receptor as quickly, so a couple different studies looking for it finds that guanfacine withdrawal is much less likely to lead to withdrawal hypertension. So I think with clonidine XR versus patch, or the extended release actions are probably more to not maintain constant coverage, but to prevent withdrawal issues. So maybe I beat that one to death or over-answered that, but that's my answer there. So Anthony Howell, and some of this is hard to suss out, asks, he's wondering about the amount of adults being diagnosed with ADHD as opposed to adolescents and children. What percent of those diagnosed was first diagnosed as adults? So there are, if we go back to the 90s, when I started work in this area, nobody was identified or diagnosed as an adult because the claim was ADHD was a condition of childhood and all children outgrew it. So even though clearly adults had it, it was roundly ignored. All of our adult diagnoses are new since that era or time. In general, what's the biggest increases we're seeing is increases, the rate of diagnosis in adults has increased more dramatically over the last decade or two than the rate of identifying ADHD in children. So there may be some incremental increase in children, and I would say that's probably reflecting largely real increases in occurrence of ADHD. With adults, the question is how much of this is just finally recognizing ADHD that's been around a long time in these individuals, particularly since ADHD's impact can fluctuate over time, and how many of them are new cases of ADHD that, for example, with a post-COVID or with a traumatic brain injury, the person wasn't functioning at any point in their previous life in an ADHD range, and now they are at a later point in time. So I don't have precise percentages, but the biggest increases recently, or relative increases, are particularly in women and adult women. But again, that's a category or group that's been classically almost certainly underdiagnosed. James Alexander asks, what do I think about an EBA brainwave system, the FDA approved for ADHD testing? So I do have a video on that. So two things to remember. One is the FDA has a much more rigorous process for approving drugs than they do for approving devices. And they also have more rigorous standards for approving treatment choices rather than diagnostic systems. So essentially, you don't need to do too much more than showing it's not causing damage and it may have some value as a diagnostic tool. Then the system described is looking at the EEG, looking at brain waves, and looking at relative ratios of theta to beta brain waves. And the claim at one point in time was that a certain pattern, and I'm not even remembering, it was high or low, was indicative or strongly associated with ADHD, and a different pattern or ratio was strongly indicative of non-ADHD. And part of that was based on really poor and inadequate control groups. And some studies subsequently have found rates that we would have classified more as ADHD are much more prevalent in the non-ADHD population than previously thought. And whether that's actually because of our environment is changing and everyone's a little bit more ADD-like, or whether because the original groups that were studied were not a broad and representative enough group of the population, I don't know. So I think it's just to me, I can't imagine too many situations where it's going to be powerfully helpful in sorting out whether someone has ADHD or not. It's highly unlikely to harm someone. It gives you a concrete measurable variable, but I'm not convinced that variable has much real life meaning yet. And I think there will be refinements on it. There will be finer ways of checking brain activity in more specific areas than just looking at relative alpha theta ratios. So I think there's a kernel of value in there, but we're not there yet, would be where I'd say. So Andrew AJ just started Strattera 12 days ago at 40 milligrams, and he feels a difference. Do I need to go to 80, or can I stay at the 40? How do I know that I'm getting the full benefits of Strattera at 40? So again, I can't make specific recommendations here. What I would say is if you are completely free of side effects and it's helped somewhat, one is, again, given that there is some... So Strattera probably has both some largely immediate effects. So you've probably seen most of what 40 can do, but there may be even some additional, and again, it may have to do with long-term effects from an MDA blockade. My general recommendation for a person in a similar situation would be probably give it closer to a month. And if at the end of the month, it feels like there's still room for benefit and you're not having side effects, then it may be reasonable to go up to a higher dose. If you're getting benefit now, I don't see any urgency in pushing higher. And particularly, again, the other issue is side effects. If you're free of side effects, then that suggests there might be room to go up. So sometimes it's useful, again, to do a trial at a higher dose, even if just what we learn is, okay, it's not tolerable at a higher dose, or it's tolerable and there's more benefits, that would be great. Or there's more benefits and more side effects, then it's a question for the individual to sort out. Does it make sense to try to continue with this higher dose and hope that the benefits continue and the side effects wane? So Matt Healy enjoyed the nature video and could relate to it. Great. There are some of the only places he feels truly at ease. Are there possible links or predispositions between ADHD and FND? So I'm blanking on the FN. I think it's something of nature deficit syndrome, or so I don't know of any research looking at ADHD as sort of the determinative variable and rates of likelihood of immersing self in nature or being particularly sensitive to nature. Everything I've looked at is primarily looking at the other direction. So I don't know. So James Alexander asks, have I seen patients succeed with clonidine after failing on guanfacine? I haven't, because usually if they've tried one medication that's so different from all the others, so it's potentially sedating, it doesn't work immediately, they're not usually willing to try another one. And again, the potential for rebound hypertension is considerably greater with clonidine, and particularly in an ADHD population where forgetting a dose, not remembering to pick it up from the drugstore, other reasons considerably increase the risk for missing a dose. It makes it a less attractive option. But there is, and I'm not remembering the precise details, but there is some suggestive evidence that aside from their basic alpha-2 adrenergic action, they may have enough difference that some people could conceivably get a better effect from clonidine than guanfacine. Dylan asks, is becoming a psych NP nurse practitioner a good career to get into? Are there any benefits to becoming a psychiatrist over a psych nurse besides a higher salary? Thanks. So it's a loaded issue, and one that people prompted me to talk about before. So part of what's difficult to sort out is one, the training is different, and it's more rigorous in terms of who is excluded or allowed in. And you could argue, so if you just look on test scores, if you look on grades, we are selecting a more, and I'll just use the very charged term, elite group to be doctors than we do to choose nurse practitioners. Does that mean those criteria are good or valid or are the most meaningful ones? No. But is there a difference between the populations who get into these programs? Yes. And then secondarily, is there a difference between the training? Yes, absolutely. There is more immersion and more in-depth awareness of the body and physiology. Is some of that irrelevant? Potentially. Is some of it important in ways we may not articulate or identify? Yes. So the training is different, both in terms of intensity and in terms of longevity. So part of it, when you're assessing group outcomes from different providers, so one of the most interesting things in the DEA's alarm about a potential stimulant epidemic in the US is that rates of prescribing stimulants by psychiatrists, and I don't have the exact numbers in front of me. I think actually I have the chart somewhere on my desktop. Pediatricians, psychiatrists haven't changed a lot in the last 20 years in terms of how many prescriptions they're writing for stimulants. Family medicine doctors have increased somewhat, but this huge change, like 9-10 times higher than it was a decade or two ago, is among nurse practitioners. Now, some of that is there's been a big increase in nurse practitioners, but they also found that the vast majority of these nurse practitioner stimulant prescriptions were writing for the exact same prescription for everybody. Now, is that a function of being less well-trained? Is that a function of having jobs in these telepsychiatry, ADHD mills where they were instructed to get as many people on? And I'm oversimplifying, but it's pretty clear this was the instruction at many places. Was it they were accepting orders from above and not individually tailoring. I mean, the data is overwhelmingly clear that the huge increase in stimulant prescribing in the US is largely driven by nurse practitioners. I mean, some of that is probably warranted and appropriate. Some of it may be overprescribing. So whether this is a good career to get into, what I should say, backing up, is the nurse practitioners that I knew in San Francisco that specifically worked with people with ADHD, and I'm thinking just of 2 individuals, so it's a small sample size, were absolutely highly intelligent, highly caring people. So I would say either one of them, and this is not meant to sound backwards or slur for people who didn't know their credentialing, assumed or thought they were doctors, psychiatrists. Again, but there are others with less training and less intelligence probably to begin with. So pay rates do tend to be different, but again, you're spending many more years and time before you're able to make that income. So I'd say I would, and different jurisdictions, different states, your ability to write prescriptions may be influenced. So some of it depends on how intensively you want to learn the material, the background material, how much financial income and job options are important to you. Again, there presumably are more job options, but well, the number of positions is going to be higher, but you're going to be more treated as a cog in the mill with an NP. So I think the mental health profession is a noble profession, and I view it as a calling rather than just a job, but I'll end that. So Max asks, I see there's a bunch of questions and not a lot of time left. Your example of birds needing to sing louder in urban environments to be heard by other birds was a nice metaphor for humans living in cities surrounded by people, and yet many feel unheard and isolated. So thanks for liking the metaphor. Some of that research was done in San Francisco on white-crowned sparrows. But with the noisy background, it's harder to be heard. Saw asks, methylphenidate for me has helped tremendously for emotional control, impulsivity, and longer concentration. Would modafinil be similar to methylphenidate or amphetamine? So there is one study out of Brown University, I believe, and I looked for it recently, I had trouble finding it, comparing one of the stimulants with modafinil, and they did some sophisticated testing, and their estimation was that modafinil actually helped more directly with executive functions, and what stimulants were helping more with was motivational factors. Be that as it may, I'd say it's harder to predict if you've had benefits from either Ritalin, methylphenidate, or amphetamine, whether or not modafinil will be helpful to you. For some people, the effects are similar with less feeling revved up, but for others, they're not. So Max found the link to the neurofeedback for ADHD. So that was talking about the EEG-based diagnostic tool. So Wesley asked, is the new book out already? So it's not finished being written. My final deadline is August for that, and then it will go through editing, and then it won't be till next year before it comes out. So, but pieces of what I'm writing are on Medium. So if you can afford $50 or $60 a year to subscribe to Medium, you get me and actually hundreds of thousands of other writers, many of which are worth reading, not all. James Alexander, other than buspirone and modafinil, what are some of the other most promising unconventional unapproved medications for ADHD? So I'm blanking on the name. There's a triple acting norepinephrine dopamine reuptake inhibitors. Sunosi, I have a video out on. Strattera, I'm blanking on the names right now. What else is out there? Amantadine, memantine may have some evidence. I have some different videos on aspects of those. Yeah, I'll just leave it at that. Oh, sorry. Matt was FND was functional neurologic disorder, conversion disorder. So I know, many ADHD is associated with many other psychiatric issues. I don't know too much about the connection between functional neurologic disorder, what we used to call conversion disorder. My expectation would be rates are higher, and one piece of it that's been studied with somewhat conflicting results is that many people with ADHD may have either less interoceptive feedback or may interpret it or ignore it more readily. And that itself, I would expect to be a factor in misinterpreting some physical signs in the body, which then could go on to create new and different physiologic signs. So the Dylan, and I talk about this in the modafinil video. So he asked, how much is a concern is Stevens-Johnson syndrome? So for years, the maker of modafinil, Cephalon, which originally was a French company, or I'm not remembering who has US rights, they went with a weird marketing strategy of getting it approved for narcolepsy, sleep shift work disorder, and obstructive sleep apnea that isn't resolved with CPAP. So they went for a tiny market and decided to charge a huge price rather than there was compelling evidence modafinil helps with a whole range of daytime lethargy syndromes, whether it's from other medications or physiologic conditions like MS. And it's safer than the stimulants in many ways for keeping people awake and alert. Anyway, they did decide to investigate it for treating ADHD. There are several dozen studies, maybe not several dozen, but numerous studies showing modafinil is effective and comparable to other non-stimulants in terms of effect size. And during the final stage after phase 3 trials for kids for ADHD, one kid in these studies developed a Stevens-Johnson syndrome, which compared to it's like third-degree burns. It's a reaction where you get blisters on your skin can slough off. It can be fatal. So it sounds silly that a rash can be fatal, but it can kill people. So this is a really serious condition. On the FDA panel for approving it for ADHD, there was one dermatologist, just happened to be among the dozen or so doctors, and the dermatologist said, this has not been previously strongly associated with modafinil. Modafinil's been around for 2 decades at this point. We see this with other drugs. It's uncommon. Some drugs are more strongly associated with it. This is not a big deal. This should not block approval. It was a psychiatrist on the panel who said, oh my God, an uncommon physical body reaction that we're not used to dealing with, don't approve it. I don't think the evidence since then has shown that the risk is particularly elevated for Stevens-Johnson syndrome compared to many of our other drugs. So it's in the range of close to 1 out of a million effect. I don't think for most people testing your genome is worth the expense to screen out. And I'm not sure even how strongly those are predicting Stevens-Johnson from modafinil. For some other conditions, that may be warranted for people from certain ethnicities who have higher rates. Maybe it's warranted. If you're that anxious and it alleviates your anxiety, that may be a convincing reason, but there's not compelling reason that we should be massively screening everyone's genome before we prescribe modafinil. So Harshul asks, are there any links between ADHD and hypothyroidism? Got diagnosed a few days ago, and on Concerta and clonazepam already for ADHD and anxiety. So there's a whole host of autoimmune. So much of hypothyroidism is autoimmune based, and there is an association between ADHD and a whole host of autoimmune conditions. So yes, is what I'd say there. So Max provided the link to the stimulant use epidemic, which refers to some of the data with the nurse practitioners. Mr. AKS, Mikhail Gorbachev. I don't know if that's asking the spot on the head. Again, that's he just signed in 5-fluorouracil to treat actinic keratoses, which can develop into skin cancer, and I don't want to get again, but probably almost certainly exposure as a teenager rather than in the last 40 years. And Max is also pointing out that for people who want to engage in longer discussions on some of these topics or more in-depth back and forth or discussion among yourselves and not just with me, we do have a subreddit set up under Dr. John Kruse. And Max also wants me to point out that I've been releasing shorts for the past few weeks, and some of them are also being released onto TikTok, if you prefer that platform. Yeah, so Steve brought up, and I discussed this in the modafinil video, that modafinil, again, was developed by Cephalon, a French company, but the huge investigative body that did most of the research or much research with it was the US military, because they wanted to enable not just fighter pilots, but ground crews, anyone who, to be able to fight 24/7. And stimulants have been traditionally used since World War II, at least. In different cultures, different stimulants, even well before that, for warfare, or preparing people for warfare. So the downside of the stimulants is that they can make some people trigger happy, aggressive, more likely to shoot when they shouldn't be shooting. So modafinil, I'd say largely the military's experience and testing kept people awake and alert and made them less likely to be trigger happy. So yes. So Max, and this is the last question I'll try to answer today, is what are the safest drugs to treat anxiety comorbid with ADHD? So the safest thing to do usually is less of the stimulant. So the stimulants in the setting of ADHD can decrease anxiety, but they can also increase it. So if someone's on a stimulant for their ADHD and feeling too anxious, the first thing I always think of doing is decreasing the stimulant dose. Second thing I would think of before adding another medication is a whole host of cognitive behavioral approaches to decreasing anxiety, and particularly helping people frame it that very often anxiety can be conceptualized as an attentional disorder. And that is, you're paying attention to something that isn't really an immediate threat right now, and that's not helpful or useful. But jumping more directly to answering the question, what drugs would I use? I would strongly avoid benzodiazepines. They work really well, but they have lots of side effects. And in many ways, they're putting you in a battle between revving up and damping down. So it's more often, I've seen serotonin reuptake inhibitors being particularly useful. And it's also a situation where buspirone, and I do have a video on buspirone, should be considered, because buspirone may well help with some ADHD symptomatology as well. I'm not a particularly big fan of gabapentin and hydralazine and other drugs, or Seroquel, which I think are mostly working through sedating rather than anxiety per se, and that to that extent maybe working against the effects of the stimulant or benefits of the stimulant. So Harshul is asking, could his higher TSH levels be induced by clonazepam? I'm not aware of any particular strong association, but also it's not something I'm completely fluent with. So again, it doesn't seem a high likelihood that the benzodiazepines aren't usually having strong autoimmune effects, but with any individual, anything is a possibility. And Sean's putting in a boost for buspirone. So thanks for listening. Thanks for the great questions. Thanks for exhausting my thoughts today. Stay healthy, stay happy. I will be back next week.